And we are on the time. So I thanks again uh, our speakers, Chairperson Dr. Amit and myself. So we are moving to the next session, that is basics of diabetes. For that I will uh, invite Dr. Snehal Tanna, Senior Diabetologist from Jupiter Hospital, Mumbai, and Dr. Sushil Patel, Senior Diabetologist from the Akshar Diabetes Center, Vadodara. So over to you, sir.
Thanks a lot. Uh, Good afternoon, everyone. And after this interesting session about the foot and quite in detail, I presume, and it was quite to the basic. Again, another basics of topics, and we will be covering three topics today. First one will be on TIR and time in range, which is now the kind of fourth dimension in the management of diabetes that we see. It will be taken over by Dr. You have the. You can.
Thank you. So our first speaker doesn't need any kind of introduction. He's a well-known speaker in India, a Professor L. Srinivas Murthy. He's a MD, FRCP, Glasgow, Edinburgh, London, USA, and many more degrees in his credit. And senior consultant physician and diabetologist at Life Care Hospital and Research Center, Bangalore. So not going in the total detail of his CV, it is mentioned over the screen. Over to you, sir, for your lecture.
Thank you, Sushil, and very nice to see you all physically. Audible? Audible, right? Okay. Thank you. And let's move on to the topic about the clinical implications of glycemic variability and the rising horizon of teneligliptin evidence, and that is with respect to the top TIR study. That is what I'm going to talk about. Before getting into the topic per se, let's look at the glycemic assessment in diabetes. What we routinely do is through HbA1c. And the limitations, I'm sure all of you are aware about the HbA1c, which cannot access the hypoglycemias or the glycemic variability basically. And it can get influenced with a simple conditions like anemia, hemoglobinopathies, chronic liver disease, iron deficiency, etc. And of course, it will not pick up your magnitude of the fluctuations which we see in a daily life in a diabetic patient. And more importantly, the intraday and interday fluctuations are never picked up with your A1C. So the management of diabetes, now there is a paradigm shift from looking around only the A1C, FBS, PPBS, than also adding on the glycemic variability and the hypoglycemia component. So all peaks do not look good in clinical practice. So the glycemic variability comprises of both postprandial glucose spikes as well as the hypoglycemic spikes. So this is what it looks at. So the standard deviations, when you calculate across these 4 points which are seen before each meal and at bedtime, do not reflect this variability, and these glucose measures are similar between the two patients which you see in two different colors when it comes to the A1C, but actual picture is this, which is picked up by your CGM. Now, what are the various glycemic variability indices? This is what we do. All of these are statistically done. Of course, as clinicians, we may not be very keen in that. So there is no generally accepted gold standard and little consensus regarding which method offers the most meaningful assessment among these. So among the most commonly used method is the standard deviation for this glycemic variability, and CGM is something which picks up most of these indices. So the serum markers of glycemic variability are these. Again, in routine clinical practice, we use only the A1C part, more common, and all these are seldom used in clinical practice. So the MAGE, or the mean amplitude of glycemic excursions, what we see in this, when it is more, the glycemic instability is higher. That is what it means. And of course, the glycemic variability will comprise of all these interconnected issues in our routine clinical practice, starting from the fear of hypoglycemia, the high A1C's, reluctance to intensify the clinical inertia from both the doctors and the patients, and the complications associated with this reluctance, and severe hypoglycemia. All this will lead on to this. And this is the evidence what we are talking about, the glycemic variability, whether it has got any clinical implications. Look at this long-term visit-to-visit glycemic variability as a predictor of both micro and macrovascular complications in diabetic patients. So there is a clear-cut evidence in this one-year study which has clearly shown the relationship between the two. So the glycemic variability is a predictor of hypoglycemia. And we know hypoglycemia is in turn associated with significant morbidity and mortality. And frequent or large glucose fluctuations independently contribute to all these complications. So you can look at this slide and the correlation, I've given the references in the brackets. Glycemic variability is an independent predictor of prevalence of peripheral neuropathy, retinopathy, and of course the variability is assessed against the arterial stiffness, again a surrogate marker, and the studies have clearly shown improved outcomes of micro and macrovascular complications by minimizing this glycemic variability. So that's the importance of the glycemic variability in clinical practice. So how do you look at this or diagnose? Obviously through CGM. I'm sure you've been undergoing a lot of training, including workshops on CGM in Diabetes India today and yesterday. And CGM clearly provides robust data about short-term glycemic control, and it gives metrics in the percentage. That's the only confusion we have, and of course now most of us are used to it. Here refers to the time actually spent by the patients in the target range, that is 70 to 180 milligrams. So 70% of the times in a given 24-hour cycle, they have to be in that range of 70 to 180. That's called time in range. And above and below are something which is above 180, below 70. Again, there are classifications you can see there. The TAR, time above range, the percentage of readings, and time spent above 250. That's called level 2 hyperglycemia. Between 181 to 250, it's called level 1 hyperglycemia. And as I said, 70 to 180 is in range. Below 54 to 69, that is below 70, is level 1 hypoglycemia and level 2 hypoglycemia. 54 and below is level 2. And that's what we do in most of the clinical trials when there is a CGM involved. The level 2 hyperglycemia is what we are always worried about. And the ADA 2022, this is what is the guidelines. You can see in the lesser shaded ones, the goal above 70%, each 5% increase is clinically beneficial, and time below range is the goal is less than 4% of the time in a given day they have to spend. These are the goals for both type 1 and type 2 diabetics, mostly given by the CGM. Now, what is the importance of the TAR? If you reduce TAR 10%, reduce, that means it's a negative. There is an increased risk of retinopathy by 60%, microalbuminuria by 40%, neuropathy by 25%. And that's the importance of maintaining the TAR in that 70 to 180 range. So whether teneligliptin has got any evidences regarding the glycemic variability component in the background of CGM is the question. So we know teneligliptin so far. There is a lot of real world evidences about the effectiveness of gliptins in Indians. We all know that. They perform better in Indian context. And this is one of the real world retrospective study which is multi-center and 12 weeks, and you can see the results very clearly. There are two studies called Treat India 1 and 2, and both of them have given us insights about the effectiveness of teneligliptin with respect to the patients with the renal impairment and also patients on different age groups, including above 65 years. There is a clear-cut evidence in these two trials, which are all, again, Indian trials. And a lot of noise was made about the QT prolongation with teneligliptin, which was seen at the not at the 20 milligrams or 40 milligrams, which we rarely use. And this is the evidence, again, Indian trials, which have seen QSET 1 and QSET 2. And what was the conclusion? These studies clearly showed teneligliptin is effective in reducing the A1C, and uptitration did not cause 240 mg from 20 to 40 mg did not cause QTC interval prolongation in Indian diabetic patients. Very clear cut, and these are all seen in a very high dosages, which is not routinely used in clinical practice. And this is a paper which talks about a review on cardiorenal safety of teneligliptin, wherein it clearly showed that there was no QT prolongation at a clinically relevant dosage. Very important. Small but significant improvement in the LV function, improvement in the adiponectin levels. This is a class effect kind, for all DPP4s, we have this increase in adiponectin levels. That is why it performs better in Indian context, and improvement in the endothelial dysfunction. Now let us quickly look at the top TAR study, which meant teneligliptin effect on glycemic control through parameters of the time in range. Now this was a prospective multicentral open label study where they studied the effect of teneligliptin on glycemic control through the parameters in the TAR metrics using the CGM. That's important. It's a CGM background study. So we know the study rationale is teneligliptin is most widely prescribed gliptin as of today in India, orally administered at a dose of 20 mg OD, and that's important, can be uptitrated up to 40 mg. There is a limited data on teneligliptin with respect to the TAR. It was not there, and hence this study was planned. So primary objectives to evaluate the percentage of time in range in patients treated with teneligliptin and to evaluate TAR, TBR, glycemic control and tolerability. 3 study sites, Dr. Unikrishnan, Dr. Bansi Sabu and Dr. Suhas Ernade. Study drugs, teneligliptin 20 mg, metformin. So, study endpoints, to look at the primary endpoints basically is the change in time in range, percentage of readings, which were from baseline to post-treatment phase 1 and phase 2. Basically, it was divided into phase 1 and phase 2 studies, which I'll just show you. And of course, secondary endpoints regarding all the TARs and TBRs ranges, which we discussed earlier, and changes in the A1C, FBS, PPBs also was considered along with your CGM. And of course, to look for any incidence of adverse events or serious adverse events. Inclusion criteria, male, female patients having diabetics above 18 years, less than 65 years were taken. Diabetics, uncontrolled and stable dose of metformin therapy at least for 6 weeks and having A1C above 7.5. The upper limit was not fixed. And people who are gliptins naive. So they has to be on a monotherapy with metformin, stable dose 6 weeks. Exclusion criteria routine, type 1, people who are on insulin, diabetic ketoacidosis, severe hypoglycemia, hypersensitivity to the drug. All these patients were ruled out. And this is the chart which talks about the study design. You can see the pre-treatment wherein day 1 to day 4, the CGM starts off from here only, day 1, before the actual patients are exposed to the drug. So day 5 onwards, the treatment starts with the teneligliptin and goes until 14. And the second one is day 33 to day 46. Basically, 46 days, about 6 weeks, the study was done. And the second CGM was post-treatment phase. So, of course, for all the patients, a uniform diet plan is applied like any other clinical trial, and there was no addition of any other anti-diabetic drug throughout this period. There was no rescue therapy, so the patients had to be dropped out if they require a rescue therapy. That was a study design. So efficacy, the assessment of all primary and secondary endpoints, safety assessment, monitoring and recording of all adverse events, SAEs. Now, what are the results? So, end of the day, we had only 42 patients remaining in this because of the patients 59 because of the CGM data could not be obtained for one patient due to device malfunction, and 44 to 42 the outliers. 2 patients with extreme values of CGM were identified as outliers and were excluded. As I said, there was no rescue in this, so they were excluded. So we had 42 patients, and of course, many of you might have questioned, this was a statistically significant numbers for the study. They're not low numbers. So parameters, the results, you can see the fasting and PP reductions, including the A1C reduction. And other parameters were looked into, and these were all the results. Of course, the glycemic parameters, what we are interested, A1C has got a statistically significant reduction. The CGM parameters, that is what we are interested in this study. Look at the mean percentage TAR, statistically significant number at the end of phase 1. Phase 1 is just 14 days. 14 days, in that 5 days, the patient was not on the drug. 5th day onwards, the drug was started. Just in 9 days, look at the achievement. So end of phase 2, of course, this is 6 weeks and it is maintained. That is what we want, sustained effect. And 6 weeks, the sustained effect of seen mean percentage of TIR, the time above range is reduced, you can see in the pink bars, and the glucose management indicator, which is one of the indices for the glycemic variability, has dropped significantly after the 6 weeks. And again, the same thing which is shown, of course, lot of statistics, but end of the day, the results are highlighted. The percentage of time in range, 70 to 180, you can see at the end of 14 days, at the end of 6 weeks, both are maintained, which is a statistically significant number. So comparison of TIR between the baseline phase 1, phase 2 for all these patients, you can again see split up, which is clearly shown the improvement. So teneligliptin was safe, well tolerated. The minor hypoglycemias were not recorded, and there were no side effects reported, unlike in any other trials. So look at this data, which is of course not related to top TIR. 3,000 patients were exposed to teneligliptin for a duration of 52 weeks in clinical trials. 300 healthy subjects were also exposed. Only 10% of them experienced the adverse events. This is just to show you the data, which is usually seen in routine clinical practice. And hypoglycemia was only 3%. Constipation was seen in 0.9%. This is in general, not related to top TIR. And of course, some of us have had earlier about pancreatitis, and this is very clearly seen. The teneligliptin is not associated with pancreatitis. Similarly, the CV risk, again, approximately 2.5 lakh patients were exposed to this, and there was no signal for any increased cardiovascular risk. There is no CVOT trial, but this is what is the data which is pulled out retrospectively. And the safety when it comes to, because our trial top TIR showed less than 65 years, and I'm showing you data where more than 65 years also the patients have been covered, and the safety is very, very clearly shown. And of course, there is an external comparison. This is another interesting top TIR compared with the CANA in combination with teneligliptin. You can see in the middle portion, it was for 5 weeks, and look at the results when you add on with the Cana. There is a definitive improvement in the time in range segment by about 11%. I think it's not working. Okay. And this is another study which is called TEDdy, the teneligliptin 20 mg versus placebo. Again, you can see the time in range CGM data, which is improved with all the parameters. So the key pharmacokinetic features and clinical benefits of teneligliptin in general, it's got a long half-life. So once a day administration, convenience, patient compliance, adherence, that advantages we have. And it can be taken irrespective of the meals. It has got a minimal chances of drug-to-drug interactions because of dual mode of excretion. And of course, dose adjustment is not required in mild to moderate hepatic or renal dysfunction. Again, these are all the convenient factors apart from the pricing in our Indian context we should think about. To summarize, teneligliptin treatment reduced the glycemic variability. There was a significant improvement in the mean TAR and TAR at the end of the study compared to baseline. And there was also significant improvement in the mean A1C at the end of the study as compared to baseline. And teneligliptin led to early glycemic improvement. That is, at the end of just 10 days, and it was well tolerated, and thus teneligliptin can be a very promising drug to reduce glycemic variability in our Indian patients, and that's the most important apart from the cost convenience, OD preparations, and dual mode of excretion. No dose adjustment is required in a mild to moderate hepatic or renal insufficiency. So thank you very much for patient hearing.
Thanks a lot, Dr. Srinivas Murthy. Are there any questions from the audience? Or I'd like to just at the end of it, or we can take right.
Yeah, we can. I think I've completed before time. So,
yes, so we can. We do have one.
Dr. Jayant Panda has got more time too.
So a question from my side, one about the TR and the one regarding in person. So about the TR, just wanted to know, you stressed a lot about TR being more relevant to the hypoglycemia.
No, both.
No, sorry, glycemic variability.
Glycemic variability.
It's more related, I mean, throws more light on the hypoglycemia versus the hyper. Is it, I mean, that's what I kind of gathered. Is it so?
No. Glycemic variability gathers both hypo and hyper.
Yeah.
But not the TAR.
Not the TR. The glycemic variability,
Yes.
does it, I mean, throw more light on the hypoglycemia as compared to the rest of the parameters that we see in our practice?
Definitely. It is a better marker because most of the hypoglycemias, especially in the night, early mornings, are not picked up, right. By the patients.
Okay, and regarding teneligliptin, just wanted to know, all these studies were with metformin or against placebo or with canagliflozin.
Yeah.
How about using this drug as a third-line drug or probably a later-on drug?
Definitely, there are evidences. There are evidences about all that. Except CVOT, teneligliptin got all the other trials versus, like the TEDdy trial was against a placebo. There was one with Cana we showed. There is with insulin. There is with SUs. All these evidences are definitely there.
One more question. Do you recommend the usage of teneligliptin 40 milligram in a day?
See, that depends on the individual patient. The recommendation is definitely there, but it's not for every patient. 20 mg, we get all the advantages of a gliptin. Teneligliptin 20 mg OD will give you that advantage. And so 40 mg, normally we don't give. I have given for few of the patients, but the effect will not be very, very statistically significant or clinically. It's OD. It's OD. That's the advantage. That's the advantage.
So how much HbA1c reduction beyond that 20 milligram you get?
No, that is again individual. I don't think we can have some marker like that. From 20 to 40 is equal to 0.5 of A1C reduction. We can't say that.
Any other questions?
Okay. Sir, yeah, you can definitely combine permutation combinations, but it's case by case basis. See, the guidelines does not tell you to combine these combinations, etc. There is now with remogliflozin, metformin, combinations, all that we use. But definitely case by case basis we can take a call. But now pioglitazone, I think DeFranco is promoting with a gliptin, SGLT2 and a pio is his favorite triple drug combination.
Thank you, sir.
Thank you.
Thank you for a wonderful lecture. So I request my coach to introduce our next speaker.
And he doesn't require slides, please. He doesn't require any introduction per se. So We invite Dr. Jayan Panda, Professor and Head of the PG Department of Medicine, SCB Medical College, Cuttack, Odisha. A huge and a big CV, National President, CCDSI, Chairman API Odisha State Branch, Governing Body Member of National API, Organizing Secretary RSSDI 2017. He has multiple international publications and national publication, and he's a principal investigator in many of these same national and international trials. He'll be speaking today on remogliflozin, one of the kind of a late entry, but took a good amount of share from the rest of the gliflozins that we know of. So over to Dr. Jayan Panda.
Thank you for that nice introduction, and it's a pleasure participating in our own Diabetes India with fond memory of Dr. Shadikot, and I must thank Dr. Arbin, Dr. Bansi and the whole team for a great show post-COVID. And just pre-COVID we had a session in Bangalore, and after that everything closed, I remember, and after COVID again we started with Diabetes India. So today's topic that have been assigned is on effect of remogliflozin on glycemic variability, the REMIT-GV trial. Before that, have a timer. Okay, and I'll just take 18 minutes. That's all. So, effect of remogliflozin on glycemic variability. The most important concept comes the monitoring of the blood glucose. Initially, we were doing hardly in days, 1 month the blood sugar. Then came the concept of A1C, the 3 months average sugar we knew, and then came the most important self-monitoring of the blood glucose when we did a testing by patient himself or by the paramedical workers. And recently, we are showing the CGM or AGM, and we are doing a ambulatory glucose monitoring hour to hour, day to day, week to week, month to month, and along with the long existing A1C, we are moving on to this glycemic monitoring, which is ambulatory, which is continuous, gives an impression on different time of the day. So regarding the drugs, we have many newer drugs, and one of the newer SGLT2 inhibitor is remogliflozin. And we know the remogliflozin is given twice a day, and in this dosing, what happens to the glycemic variability, postprandial hyperglycemia in Indian type 2 diabetes patients is a big challenge, and this study comes as first of its kind for this evaluation, the REMIT-GV trial. We'll have a look on this, but before that, the glycemic variability and postprandial hyperglycemia, especially in Indian setting, I'll touch upon. So already I have told that this fluctuation has to be minimum, this day-to-day, hour-to-hour fluctuation, and we determine the time in range, the mean amplitude of glycemic excursion, the coefficient of variation to detect that. And you can see this picture where two subjects, subject 1 and subject 2, with A1C 8, the fluctuations are very high in the first subject, whereas the second subject has a very narrow fluctuation, and more hypo and hyperglycemia in the first subject. But from a A1C, you cannot know that the patient has undergone this much of variation. That's why the glycemic variability came into picture and gaining popularity. You heard the previous lecture by Dr. L. Srinivas Murthy related to that. So when the variability is less is the micro and macrovascular complications, increased cardiovascular events are controlled, and all the autonomic dysfunctions the severe hypoglycemia risk all come down. So that we have to keep in our mind. And during this postprandial hyperglycemia, every meal a patient comes, it comes with a big wave of blood glucose resulting in oxidative stress, and that ultimately leads to endothelial dysfunction, smooth muscle proliferation, and cardiovascular events. So our purpose is to avoid the postprandial hyperglycemia, avoid these glycemic excursions, and this variability have to be kept in range. Regarding meal pattern, all of you know about your patient's diet, that for last 50 years the Indian diet has not changed. It's carbohydrate, carbohydrate, and carbohydrate. In average, we get almost 64 to 65% carbohydrate in our diet, and protein hardly 15 to 20%. So also the fat. So that results in a very high postprandial or glycemic excursion. This is the START study by Professor Shashank Joshi et al. And this shows in type 2 diabetes and non-type 2 diabetes group, there is no much difference. The carbohydrate intake are almost equal, and it's 64.1% of total energy from carbohydrate source. And the meal pattern affects the glycemic variability, including postprandial excursion, because patients having carbohydrate have a very high glycemic excursion. And this study has studied the postprandial blood glucose. This has been tried in two important drugs. One is remogliflozin, the SGLT2 inhibitor, which has been launched recently, and the dapagliflozin, the older one, which is given once daily. And this is assessed by the CGM, the continuous glucose monitoring in the Indian patients of type 2 diabetes. In nutshell, I am telling about the study rationale that all of you know, that this remogliflozin is twice daily, and dapagliflozin is once daily, and it has been compared in phase 3 study of remogliflozin. But being twice daily, its effect on the glycemic variability show also the postprandial hyperglycemia was checked, and the study was conducted to evaluate the effect and compare with the dapagliflozin, show also the adverse effects of the drug. And the primary and the secondary objects, as I told, was taken with two groups, and 4 centers have conducted around 33 patients of remogliflozin and 32 patients of dapagliflozin. This is the inclusion criteria in adults with A1C 7 to 9 with a stable therapy, metformin monotherapy or dual therapy with gliptin, the random blood glucose less than 300, because above that we give insulin, and a compliant dietary regimen for more than 6 weeks prior to screening was taken, and the usual factors like decay, the arrhythmias, the GFR coming down, acute infection, they are all ruled out. So the CGM device implanted on day 1, the Remodapa introduced from the day 5 onwards, CGM device removed on the day 15, and Remodapa continued. Again, new CGM device was put on day 33. The CGM device continued for 14 days and removed on the day 47. So this was a total day 1 to day 46 trial, and the first CGM and second CGM was done on 1 to 4, 5 to 14, and 33 to 46 in phase 1 and phase 2. And the baseline data was taken on the first 5 days, and dapagliflozin and remogliflozin related issues were ensured. So this is the study flow with the parameters, as you see, the age, sex, BMI, duration, all matching, and A1C, the mean glucose, time in range, the mean postprandial glycemic excursion coming in a different way. But this is not statistically significant. The comparison of the glycemic parameters from the baseline to phase 1, we'll see there are few parameters. The green one are statistically significant in this mean glucose, mean amplitude of glycemic excursion, coefficient of variation, as well as mean postprandial glycemic excursion. The red one are not. So here all these data of both the drugs, where some were significant, some were not significant statistically, were analyzed and compared, and the glycemic parameter values from baseline to phase 2 were seen taking this criteria. So if you take TIR, there is no significance in the both the groups. Both have tried to maintain it, a significant improvement, but no significant difference in the improvement observed between the Remo and the DAPA. And here the baseline to phase 2 trial, if you'll see in the Remo, there was statistically significant reduction the glycemic parameters in breakfast, lunch, and the dinner. The postprandial 1 hour, postprandial 2 hour, all three were statistically significant against the dapagliflozin not coming out. So the mean overall mealtime change in the mean postprandial glycemic excursion from baseline to phase 2, if you'll see here, the all three in postprandial 1 hour, if you'll see the statistical significance come in few, and only in dinner time the dapagliflozin data is statistically significant. And the mean change in postprandial 1 hour from baseline to phase 2 again has the star one. You can see the breakfast, lunch, and dinner with remogliflozin is significant, but in DAPA it was not significant at any point of time. So overall mealtime change in the postprandial 2 hour from baseline to phase 2. This is also again the data comes all breakfast, lunch, and dinner in the remogliflozin, whereas in the DAPA group it's breakfast and dinner and lunch is not there. So fewer included and fewer not included here. And the mean change is in continuous glycemic profile across 24 hours. If we'll see from the baseline to phase 2, the more reduction seen with the remogliflozin compared to dapagliflozin, especially in night time. The nocturnal blood glucose with remogliflozin treated patients were significantly low in contrast to the dapagliflozin patients. So here, if we put the postprandial peaks like breakfast, lunch, and dinner, and put the remogliflozin curve, the dosing in the postprandial glucose control, the mechanism may be that in twice daily dosing, we are getting a better control, taking peaks of the glycemic excursion that results in a statistically significant control of the glycemic variability and postprandial excursions. So the conclusions which were taken in this randomized active control open label study of 6 weeks duration to evaluate compare the glycemic parameters and the remogliflozin compared to dapagliflozin using 24 hours continuous glucose monitoring. Three important things we can conclude here. One is a significant improvement in TIR and A1C levels with both the groups, but no difference between the groups. Here we didn't get any statistically significant group between dapagliflozin and remogliflozin. Second most important thing is the significant improvement in postprandial glycemic parameters, where mean postprandial glycemic excursion postprandial 1 hour and 2 hour with remogliflozin, but non-significant with dapagliflozin. Specifically, the postprandial excursion is not there with dapagliflozin. And third, there is significant improvement in postprandial glycemic parameters at almost every meal, that is breakfast, lunch, and dinner, and 8 out of 9 are very well regulated in the Remo group, whereas the fewer, that is 3 out of 9, are controlled with the DAPA group. And similar adverse events are found in both the groups. So with this, I can summarize that the glycemic variability control in terms of both long-term parameters like A1C and short-term parameters like time in range, the coefficient of variation, the mean postprandial glycemic exertion should be the main objective of anti-diabetic therapy. If you have not practiced, I'm sure that many of you have practiced, because there is no much change or the technical challenge in a small setup to practice this. So this is a very scientific, very simple, and with a simple Libre Pro you can put the monitoring and know up to 14 days glycemic variability. You can keep for 3 days, 5 days, 10 days, 14 days, like that. And the postprandial hyperglycemia is independent of risk factors for CVD and has shown to further increase the risk of CV events in diabetic patients. So we have to target minimizing the glycemic variability as well as postprandial hyperglycemia in these patients. And the Indian meal pattern has high carbohydrate meal per day, contributing to more postprandial hyperglycemia, that also all of us know and has been proved and is fixed for last almost 50 years time. So this study, I'll take two conclusions before I end. The remogliflozin and dapagliflozin have both showed similar significant improvement in glycemic variability parameters like A1C, time in range, and the coefficient of variation. But for postprandial glycemic parameters like mean postprandial glycemic excursion, first and second hour postprandial blood glucose, the improvement was significant with remogliflozin but not with dapagliflozin, and significant improvement in almost every meal, that is breakfast, lunch and dinner, was found with remogliflozin, but a few meal time with dapagliflozin. So from this we can conclude that maybe because of its twice daily dosing, the excursions and postprandial peaks are better controlled, which this study, the REMIT-GV, shows. So what we are thinking that giving this drug twice a day has some challenges of dosing and the patient compliance has come as an advantage here to assure our patients glycemic excursion control and postprandial blood glucose control, which in long term result in prevention of the micro and macrovascular complications and also a good metabolic memory. Thank you for the attention, and we can take questions.
Thank you, sir, for this wonderful lecture. If you have any question in the audience.
Is around 2 hours, this is 4 hours. We give 3 times in a day.
In all the international trials and all the phases of the clinical trials, this has been used as twice daily only. So 3 times with the extra advantages are not come across. I don't know if somebody has gone through. Nowhere as per the pharmacokinetics only twice a day. In all the trials they have advocated twice a day.
But sir, reverse is true in India, that once in a day usage is more common in India.
Yeah.
Or
the compliance is much
yeah.
better, because patient is not only on anti-diabetic drugs. He is on an antihypertensive, on a lipid lowering, with an antioxidant, maybe with a thyroxine, maybe with a hyperuric acid drug. So with this polypharmacy, the compliance is better is in once daily. That's why so much of extended release, sustained release, combination pills they come up. But this is the advantage that we get here, comparing the once daily SGLT2 inhibitor and twice daily SGLT2 inhibitor. That same with gliptin also. Once daily gliptins are more preferred, but maybe they have to be seen regarding their glycemic excursion. Here the once daily, all Cana, DAPA and EMPA, we are giving once daily, but Remo twice daily. But here this study has a clear evidence of statistically significant decrease in the variability as well as the postprandial excursion in view of the Indian type 2 diabetes patients with high carbohydrate intake, which is not true with our western part. They have almost half of the carbohydrate load than that of ours.
Sir, in your opinion, which is the better molecule, DPP4 or the SGLT2 for the controlling this glycemic variability?
We have used both the drugs very rampantly, and both profile are different. DPP4 is a, I'll tell, benign drug. It doesn't have much side effects. Very silently it does its work, and safety profile is very high. DPP4. The SGLT2 inhibitors are extraordinary drugs in the form of cardiorenal protection. Besides A1C, both dose A1C reduction, besides that, this is pleiotropic effect is very good. And if you think of atherosclerotic cardiovascular disease or patient of DKD, early DKD, you have to give SGLT2 inhibitor and GLP-1 as a preventive measure as per the recent guidelines. You asked regarding the glycemic excursion. You see, glycemic excursion is controlled once the blood glucose fasting postprandial comes down, and round the clock it is maintained through that range, time in range. So regarding the glycemic control, it doesn't have much variation if it's properly combined with other drugs, and as per the A1C and fasting postprandial, the doses are suited to keep the blood glucose between say 130, 140 fasting and 170, 180 postprandial. But regarding the pleiotropic effect, SGLT2 inhibitors have an advantage. At the same time, you have to be careful regarding the all issues which are coming, like the euglycemic ketoacidosis, like the genitourinary infections, like now the fasciitis and the corneous gangrene. The many things starting from the gangrene to ketoacidosis, they are coming up. But in my practice, with proper instruction of genital hygiene and good fluid therapy, not a single case of any of this side effects, because only thing you have to spend little time with the patient telling about the precautions, and there are no drug. I'll tell two best groups of drugs now in anti-diabetic regimen are the GLP-1 agonist and the SGLT2 inhibitor. Active
Active life.
active metabolite, pharmacologically active metabolite, they also contribute, and pro drug which we tell, they also decide the dosage pattern.
Please come and tell about the benefits of DAPA and being about the same thing about Remo. We know it appears to be a class effect. But how do we, I mean, for all of us, how do we answer this sometimes when we also take lectures, we are asked the same question.
Yeah.
So how do we answer this particular aspect?
Yeah, this is a very common query in a doctor's mind. Here I'll tell, you see, whoever, like my previous speaker was telling about teneligliptin. You see, sitagliptin, vildagliptin has many more trials in their favor in comparison to the gliptins which are relatively launched later. So if you tell Cana, Dapar, Empa, there are lot many CBOTs and trials in their favor. Remo has relatively come later to the market. So in view of that, the studies are less, but there is definitely class effect. There is definitely affordability for Indian patients. Now there are few drugs are getting off patent and coming to the market. That's a different issue. But initially, when this drug was launched, that was only afforded gliflozin by many. So that makes a drug studied very elaborately, and we can have more publications in favor of that. But happened with the teneligliptin. Teneligliptin became the most prescribed gliptin world over because of Indian patients and because of affordability. So similar scope was there, but by this time few gliptins have become off patent, and they are becoming available at the similar range. So they have become competitors. So more we use, more we'll know about the molecule, and definitely there is cardiorenal protection of remogliflozin at par with other established gliflozins like EMPA, like DAPA, and also CANA.
Thank you, sir. Any questions?
Sir. Yeah. Yeah, that happens. That happens. Actually, maybe here it shows in comparison to dapagliflozin better glycemic control by the remogliflozin group in the night also. Nocturnal reduction is also good. That may be because of the drug levels which has been taken in the second dose, maybe post-launch dose, which controls the night blood glucose. So maybe that part in the elderly patient also to be instructed properly.
Sometimes.
Yeah.
So basically, regarding SGLT2 inhibitors, the moment your glycemic range comes below 160, 180, 160, the chances of polyuria reduces, because then anyway the threshold, if your blood glucose levels go below the threshold, the chances of polyuria is less.
The osmotic symptoms are
over,
less.
over the period of time, sometimes what you're saying is right. I mean, we do have to tell the patients that once the glucose levels start dropping down, these symptoms might reduce. You have to take. Thank you. Thanks a lot, Dr. Jayan
Thank you.
Panda.
Thank you.
And so the last session today over here for the basics, we have Dr. Shanmuga Velu. He's a consultant diabetologist. He finished his MBBS from Madras University and MD also from Madras University. He's an FRCP, Glasgow, UK, FICP from Indian College of Physicians. He has a lot of, a huge CV as usual. Everyone knows him as a good teacher, and has presented papers in various forums as well as participated in various clinical trials as well. So we all know that what we eat does cause changes in your blood glucose level. He's here to talk about gut microbiota and diabetes.
Respected chairpersons, co-speakers, senior doctors, and my doctor friends, I feel extremely happy, honored, and most privileged to have been invited to make a presentation on diabetes and gut microbiota with a particular focus on outcomes. I thank Dr. Bansi Sabu and Manoj Chawla for their kind invitation. So my disclosures, what I'm going to do for another 20 minutes. So first introduction. So eukaryocytes, bacteria and archaea residing in the gut, they are collectively known as the gut microbiota. Inclusion of gut environment and the inhabiting microbial genome, it represents the gut microbiome in which bacteria are the major constituents in the gut. Several studies identified that changes in the quantity and diversity of gut microbiota have significant importance with reference to progression of many metabolic disorders. So human gut microbiota, it provides protection against pathogens, also improves the immune system. They also play a crucial role in maintaining the intestinal integrity, homeostasis of gut epithelium, as well as metabolizing the xenobiotics, including the drugs. So adjunct therapy with a probiotic like lactobacillus, it's it's not appearing here. It's not moving. It's moving slowly. So I have gone through already. Right. So adjunct therapy with the probiotic, that is live beneficial commensal bacteria species like lactobacillus and bifidobacterium, has been in use for a long time. In addition to probiotics, resistant fibers that promote the growth of beneficial bacteria, they're known as prebiotics. This biosis can cause numerous diseases like inflammatory bowel disease, ulcerative colitis, and can also lead to metabolic diseases like obesity, diabetes, and non-alcoholic fatty liver disease. So microbiota. In 2001, Joshua Lederberg, a former Nobel Prize winner, first defined the human microbiome as an ecological community, commensal, symbiotic, and pathogenic microorganisms that collectively share our body space. Human health is strongly influenced by microbiota. An adult human is colonized by approximately 100 million microbes, predominantly in the gastrointestinal tract, of which the largest population resides in the colon. Rodents and humans differ in certain aspects of the physiology, but animal models, they provide valuable opportunities to conduct investigations. In the vast majority of gut microbiota, they belong to four main families, namely Firmicutes, Bacteroidetes, Proteobacteria, and Actinobacteria, and of course we have the smaller but relevant phyla. So under normal physiological conditions, Firmicutes constitute nearly 64%, Bacteroidetes nearly 23%, so both together constitute nearly 90%, Proteobacteria 8%, and Actinobacteria 3%. Evidence suggests that gut bacteria can influence human health either directly or indirectly, and disruption may increase the prevalence of obesity, type 2 diabetes, arthritis, cancer, etc. According to this particular author, the microbiota community differences between the participant cohorts. So normal physiological conditions, I told you 90% it is contributed predominantly by Firmicutes and Bacteroidetes. With the onset of type 2 diabetes, with reference to type 2 diabetes cohort, 90% is contributed by Firmicutes and Bacteroidetes. But very important thing is there is a change in the ratio between the Bacteroidetes as well as the Firmicutes ratio. So the interaction between the human body and the intestinal microflora appears to start at birth. The development of microbiome, it goes through three fundamental stages, namely the developmental stage, transition stage, as well as a stable period. And 90% of the bacterial species, they present in the gut of the adults. So depending upon the anatomy, abiotic environment, and diversified functions of the different parts, the microbial composition may also broadly differ. So healthy adult hobbits, several colony forming units in the whole gut with a mass weight of about 1 to 2 kg. The colon alone contains 109 to 100,012 colony forming units, followed by jejunum as well as ileum. So if you look into the transfer of microbiota, it takes place in the utero or during birth. They achieve stability around 2 years of age. So in addition to genetics and environmental factors, early exposure to microbes during birth plays an important role. So exposure to vaginal microbiome during delivery, skin microbiota during cesarean section, and antibiotics in neonatal and early childhood play a significant role in shaping the stable gut microbiome. Next is gut microbiota and its functions. So main physiological functions are food digestion, absorption, enhanced host immune, development of immune cells, biological antagonism, anti-tumor response, and also helps in the synthesis of beneficial compounds, harvesting energy, that is very important, as well as vitamin synthesis. Once the gut microbiota is out of balance, series of disease would be induced. So first is regarding the short chain fatty acids, namely acetate, propionate, and butyrate. They are a metabolite produced primarily by the intestinal bacteria to metabolize dietary fibers. So we have the complex polysaccharides. They are digested and they are fermented by the microbacteria, resulting in the generation of short chain fatty acids. And that short chain fatty acid plays an important role in metabolizing the dietary fibers. So short chain fatty acids, they affect the glucose metabolism and insulin sensitivity by stimulating the secretion of peptide YY as well as glucagon-like peptide 1, increase the intestinal gluconeogenesis. They enhance the glucose uptake peripherally by increasing the expression of glucose transporter 4, and in skeletal muscles, they reduce the glycolysis leading to greater glycogen synthesis. Next is energy supply. It accounts for nearly 5 to 10% of total energy consumption in normal colon, especially butyrate. It also maintains the integrity of the intestinal barrier by increasing the expression of the transcription factors. There are many tight junction proteins which are upregulated and which are overexpressed when the butyrate generation is on the higher side. And it also maintains the intestinal anaerobic environment because butyrate activates the PPAR gamma in colon cells and as well as drives the energy metabolism. It also prevents the abnormal proliferation of opportunistic pathogen. So in that way, the dietary fibers play an important role. Next is enhanced immunity. So butyrate has anti-inflammatory effect by promoting the production of regulatory T cells. They have the ability to activate the parasympathetic activity, promotes glucose-stimulated insulin secretion. It has a capacity to cross the blood-brain barrier, leading to the enhancement of expression of various neuropeptides. Next is indole propionic acid. It is derived from the bacterial aromatic acid metabolism or catabolism. It is highly correlated with the dietary fiber intake. It provides potent radical scavenging property, that is, it possesses antioxidative capacity, and it may also provide protection of the pancreatic beta cell from damage associated with the metabolic and oxidative stress. Next is bile acids. They are secreted in the intestine. They are converted into secondary bile acids. So bile acids converted into primary, secondary. These secondary bile acids are normally metabolized by the gut microbiota. In that, they stimulate the FXR, that is farneside X receptor, and leads to the release. It leads to improvement with reference to insulin sensitivity. They also activate the TGR5 receptor, promoting muscle energy consumption and causes altered structure, function, and stability of intestinal flora. And recent studies shown that the metabolism of bile acid is abnormal in a patient with a gut microbial dysbiosis, and that increased secretion of secondary bile acids such as lithocholic and deoxycholic acid plays an important role in that it stimulates the release of 5-hydroxytryptamine from enterochromaffin cells, resulting in reduced insulin release as well as enhanced glucagon secretion. So that is very important. So bile acids play an important role. Next is lipopolysaccharide. High levels of serum lipopolysaccharides are mainly produced by gram-negative bacteria, and they play an important role in the pathogenesis of type 2 diabetes in that it recognizes the toll-like receptor, number one. It also activates the nuclear factor kappa B inflammatory signaling pathway, characterized by increased circulating levels of the inflammatory markers or the cytokines. And beta cells are damaged by the inhibited insulin secretion mediated by downregulated expression of the PDX1 gene. Next is branched chain amino acids. They are primarily synthesized by the host. Cannot be synthesized by the host, must be obtained from the diet. And elevated plasma levels of BCA, it's a risk factor for type 2 diabetes and insulin resistance. And it is closely related to the mTOR signaling pathway, and it also increases the oxidation of free fatty acids and also activation of the phosphoinositol 3 kinase pathway. Next is imidazole propionate. It's a product of histidine metabolism, which affects glucose metabolism through mTOR signaling pathway. This propionate increased in pre-diabetes as well as in patients with the type 2 diabetes, and they are possibly correlated with reference to systemic inflammation. Next is gastrointestinal barrier function. It plays a preventative barrier to various powerful harmful substances, play an integral role in the regulation of the immune system. And very important thing, patient with the type 2 diabetes, there is a significant enhanced permeability. This alteration in permeability leads to translocation of the bacterial flora and from the gut epithelium, resulting in metabolic endotoxemia, and it ultimately leads to low-grade inflammation. So this lipopolysaccharide plays an important role in chronic low-grade inflammation, which is associated with the patient with the type 2 diabetes with an impact on the insulin resistance. So type 2 diabetes characterized by chronic low-grade inflammation with abnormal expression as well as production of numerous inflammatory mediators. So individuals who have reduced amounts of butyrate producing microbe, it results in low-grade inflammation in the gut, which in turn ultimately results in insulin resistance, and through the activity of lipopolysaccharide, which is an essential component derived from the gram-negative bacteria. So this lipopolysaccharide recognizes toll-like receptor. They activate the nuclear factor kappa B, and ultimately resulting in increased circulating levels of pro-inflammatory cytokines. And the activation of the serum kinases, in turn, it affects the intracellular insulin signaling pathway. So the release of pro-inflammatory cytokine disrupts glucose metabolism as well as insulin signaling. In the long term, it has been associated with defective gene transcription of various intracellular insulin signaling pathways. So the main mechanism between gut microbiota and type 2 diabetes. We have the dietary fiber, its positive impact. We have the bile acids, which are converted into primary and secondary bile acids. Next, we have the histidine, which is converted into imidazole propionic acid. And we have the gram-negative bacteria, which results in the generation of lipopolysaccharide. So next is gut microbiota and carbohydrate metabolism. So production of metabolites during fermentation of the microbial action on the various food. The resulting secondary effects include activation of the inflammatory cascades, disruption of the permeability of the intestinal mucosal barrier, and direct signaling action through insulin secretion. So patient with the type 2, they demonstrate an environment in that it predominantly affects the transport of glucose, branched chain amino acid transportation, methane metabolism, as well as xenobiotic degradation and metabolism, as well as sulfate reduction. The same cohort displayed reduced levels of bacterial chemotaxis, flagellar assembly, butyrate biosynthesis, metabolism of the cofactors, as well as vitamins. So the microbiota, influence of glucose metabolism. We have the metabolites, namely short chain fatty acids, branched chain amino acids, indole, as well as imidazole. And inflammation, there is excess of lipopolysaccharide. Next is we have the bile acid converted into primary as well as secondary bile acids, and we have the gastrointestinal tract mucosa, where the bacterial permeability plays an integral part in maintaining the integrity of the epithelium. Next is role of diet in shaping the gut flora. So diet is a crucial regulator of intestinal microflora. The composition of the microbial community ecosystem, it is always dynamic. It is dependent upon many factors, and the gut microbiota is easily altered by dietary changes. We can see changes within 24 hours. It is also a vital regulator of gut microbiota. The composition also varies with an individual's age, and varying compositions of the gut microorganism has been identified in different geographical regions, and they may also be related to different regional eating habits. There are evidences to confirm that consumption of the animal derived food leads to the adaptation of the gut microbial function towards increased catabolic process. So there is an alteration with reference to microbial changes, namely there is increased prevalence of bacteroides. In contrast, diet rich in plant, which favors the growth of the prevotella. And that plant derived foods, the gut microbiota produce more saturated fat, enzymes involved in anabolism, and there is increased synthesis of various enzymes. So it is anabolic. On the other hand, the animal derived foods, it's always catabolic. So if you look into this particular diagram, it clearly shows the plant material rich diet. It alters the microbial flora, and that it is associated with increased generation of short chain fatty acids. And very important thing is it also plays an important role with reference to immune homeostasis, insulin sensitivity, and maintains the gut integral activity. Next is animal product on the other hand. It induces changes with reference to microbial flora, and there is reduced generation of short chain fatty acids, and it is catabolic and associated with increased circulating levels of inflammatory molecules that alters the intestinal permeability as well as the integrity, leading to metabolic endotoxemia and inflammation. So the schematic view of gut microbiota under healthy and disease conditions. So under healthy conditions, the gut permeability is intact, the tight junction proteins are upregulated, no change in intestinal microbiome. In patients who are eating a lot of animal food, there is an alteration with reference to gut permeability, alteration with reference to tight junction protein, and changes in the intestinal microbiome. And very important thing is there is activation of the cannabinoid receptor 1 also. And changes in the gut microbiome due to the use of clinically important antibiotics. So antibiotics can alter the microbial flora. So the interplay between diet and the gut microbiome with reference to healthy condition, with reference to diabetic conditions, patient with the type 1 as well as patient with the type 2. So let us look into gut microbiota and its relation to diabetes. So type 1 diabetes. Both type 1 and type 2 are associated with complex immune system and gut microbiome interactions. So the gut microbiota of preclinical type 1 patients characterized by dominance of bacteroid, that is lack of butyric acid producing bacteria with low stability and diversity of intestinal flora. The concept that pathogenesis of type 1 that is affected by gut microbiota has been well established only in animal models, but human studies on the microbiome in type 1 are still low. So human studies clearly showed that acetate diet reduces the frequency of autoimmune T cells, butyrate diet increases the number and function of the regulatory T cells, and unlike type 2 diabetes, cancer of whole microbiome may not reduce the incidence of type 1. Next is the development of type 1 has been linked to aberrant intestinal microbiota. Next is with reference to type 2. So majority of the studies reported association between specific taxa as well as the disease or its phenotypes, and changes with reference to inflammation as well as changes with reference to other gut permeability. So first is the microbial genera, most frequently found to be associated with the type 2. So shown in blue, that is negatively associated or correlated. Shown in red, positively correlated with reference to increased prevalence of type 2 diabetes. So the potential mechanism of microbiota, its effect on metabolism in patient with the type 2. It modulates inflammation, interacts with the dietary constituents, it affects the gut permeability, the glucose lipid metabolism, insulin sensitivity, as well as overall energy homeostasis. So overall, type 2 diabetes is associated with the elevated levels of pro-inflammatory markers. So these markers and lipopolysaccharide, they are recognized by the toll-like receptors. And very important thing is, if you look into the interleukin 22, it has anti-inflammatory cytokine, which can restore the insulin sensitivity and also inhibits the pro-inflammatory cytokines. And increased intestinal permeability is a characteristic feature of patient with the type 2. It results in translocation of the gut microbial products, ultimately resulting in metabolic endotoxemia as well as low-grade inflammations. And probiotic bacterium decrease gut permeability, and very important thing is it causes upregulation of the intestinal tight junction proteins via several mechanisms. So butyrate produced by certain bacterial microbe also have potential to reduce the gut permeability through serotonin transporters as well as PPAR gamma pathways. These are all various mechanistic pathways that results in the increased susceptibility to develop type 2 diabetes. It also affects type 2 by influencing glucose metabolism. Very important thing is the bifidobacterium can increase glycogen synthesis. It can also improve the translocation of glucose transporter 4 as well as insulin stimulated glucose uptake. And very important thing is it has a potential anti-diabetic effect and also upregulates the genes which are often associated with the various intracellular insulin signaling cascade protein transcription factors. It also decreases the insulin degrading enzyme and increases the adiponectin levels in patients with when lactobacillus are given. Next is some species of lactobacilli and Akkermansia. They possess potent alpha glucosidase inhibitory activity, and the microbiome can modulate gut hormones and enzymes. They improve insulin resistance as well as the glucose tolerance. So bifidobacterium and lactobacillus produce bile salt hydrolysis, and secondary bile acids in turn activate the membrane bile acid receptor to induce the production of GLP-1. Next is fatty acid oxidation. Very important thing is fatty acid oxidation as well as energy expenditure. They reduce the synthesis of acid, ameliorates obesity and consequently patient with the type 2 diabetes. And that Akkermansia and Bacteroides, Lactobacillus, they have been reported to increase fatty acid oxidation in adipose tissue and shown to reduce the obesity by increasing fatty acid oxidation genes. So not only promotes fatty acid uptake oxidation, but also it upregulates the genes responsible for fatty acid oxidation. So the main mechanism of gut microbiota affecting insulin resistance and diabetes is shown in this particular slide with reference to microbe, lipopolysaccharide, bile acid metabolism, as well as TGF4 pathway. Therapies for type 2 diabetes based on gut microbiota. So diet rich in complex carbohydrates. The very important thing is they reduce inflammation, can increase the diversity of gut microbiota, and can enrich the short chain fatty acid producing bacteria and prevent the growth of harmful bacteria, and they increase insulin and A1C levels in patients with the diabetes. Very important exercise. So the studies have shown abundance of bacteroids increased after exercise training, while the abundance of Clostridium genus and other microbes are very much decreased. Next is probiotics. They generally gram-positive bacteria. They are defined as live microorganisms. They also play an important role, and that meta-analysis of clinical trials showed probiotics could effectively reduce fasting insulin as well as A1C and improve the efficacy of HOMO-IR. Next is we have the prebiotics, that is the food components such as indigestible polysaccharides or fiber that beneficially affect the host by stimulating the growth or activity of one of the limited intestinal microbe. Likewise, a mixture of pro and pre, we have the symbiotics. Next is FMT, that is fecal microbiota transplantation. After 6 weeks of treatment, the insulin sensitivity is significantly improved, and including the butyrate producing bacteria, the population also increased. So anti-diabetic drugs, metformin, it inhibits the growth of the B fragilis by modifying the metabolism of folic acid, increases the secretion of GLP-1 and regulates glucose metabolism. It also increases the abundance of probiotics. And acarbose complete acts in the intestine, which may partially affect the composition of distal microflora. So conclusion, it plays an important role in type 2 diabetes by exerting effects both in composition and function, and degrees of butyrate producing bacteria and reduction of butyrate are common in patients with the type 2. Several factors associated with the gut microbiota have been elucidated in patients with the type 2 diabetes with reference to short-chain fatty acids, bile acid metabolism, lipopolysaccharide, branched-chain amino acids, and imidazole propionate. And gut microbiota not only be used as diagnostic biomarker, but a potential therapeutic target for type 2, and elucidation of the precise role and mechanism of gut microbiota in type 2 will provide novel insights into developing individualized therapy for type 2 diabetes. So before I conclude, on behalf of the organizing committee of RSSD 2022, I invite all our participants to attend this RSSD 2022, going to be conducted on October 6, 7, 8, 9 in Chennai, and make this a memorable event. Thank you very much for their kind listening.
Thanks a lot, sir. I mean, it was a true classroom lecture encompassing, I think, all physio, biochem, patho, and I don't know, I mean, a lot of things. You did mention about animal products consumption versus
Yes, animal product versus plant derived.
Kind
yes.
of almost scared those who are non-vegetarians over here. But a simple one-line kind of suggestion for our patients, what should they have so that their gut microbiota is not
So the thing is, taking non-veg meal is not absolutely contraindicated. But you can take limited quantity along with the plant-derived foods in plenty. If you take plant-derived foods, definitely it will restore the microbial composition with reference to quantity as well as diversity, and that this complex polysaccharide undergoes generation of short-chain fatty acids. This short-chain fatty acid plays an important role with reference to maintenance of the intestinal barrier, integrity of the intestinal epithelium. And very important thing is it also plays an important role indirectly with reference to glucose metabolism as well as energy harvesting.
Thanks a lot, sir.
Yes, Vinay. Thank you so much. It's a very relevant question, but the thing is that as far as the data is concerned, only limited. And these trials are conducted only in a small number of patients, only for a short period of time, and there are no definite markers. Number two. Third important thing is if you look into the results are encouraging. So I will say it's an emerging field, not of any particular data to say this will definitely. But as of now, the recommendation is if you follow a meal plan in such a way, we take the meal which may not alter the microbial composition, then it will be beneficial. Yes, sir. Yes, sir. Yes, sir. Yes. No, as of now, the recommendation is only with reference to the food, not with reference to the formulations that are being manufactured and promoted by the pharma company. No. So yogurt, it's a very good probiotic, no problem at all. Fermented milk is a very good. So also miso, right. Next is fermented vegetables like cucumber, fermented vegetables like onion, radish, cauliflower. They provide very good pre as well as probiotic. Lime juice with honey, it provides very good pre as well as probiotic. No, we should ferment it in a proper manner, proper way, yes.
So thank you, Vinay. You are next, actually. So thanks a lot, sir. And